Guys, good evening, good evening. All right. Right, welcome to the second session of the video-based question series that we have done. The first 10 we have already completed. Now you're doing the second 10 of it. So I'll be again orienting you to the type of the question, how the video is going to play out, and what are you supposed to diagnose from that particular video. So we'll start with the question number 1. I have a 46 years old male presented to us with the swelling in the inguinal region. Okay, the following test has been performed. Identify the test performed. So it's simple. I'm going to show you a test of the inguinal hernia and you have to tell me what test is this. As simple as that. Now the video is this. So it's a very short video and I want you to observe what is happening. This is the index finger I have put inside it in the inguinal region. Now you see here. I've put the finger and now you can see we are asking the patient to cough. Now as the patient coughs, right, you can see the impulse is positive and your finger is moving, right? So what do you think is the diagnosis? I have a 46 years old male presented with swelling in the inguinal region. The following test has been performed. What test is this? Is it a 3-finger test? The answer is no. It is not a 3-finger test. 3-finger test is what we call it as the Zeeman test. This is what we call it as the Zeeman test. And the Zeeman test, we use 3 fingers, right? What are 3 fingers? You will use the number 1 index finger, the middle finger, the ring finger, right? The index finger is going to be at the superficial inguinal ring. This middle finger is going to be at the deep inguinal ring, and this is going to be at the femoral ring. This is not the Zeeman's test. Is it a finger invagination test? Absolutely correct. So the answer to this question is finger invagination. I'm going to take my index finger, insert in the superficial inguinal ring, and reach to the deep inguinal ring. I'll ask the patient to cough. Now, when you see here, again a very specific thing. I've taken my index finger from the superficial inguinal ring to the deep inguinal ring. So here you have your superficial inguinal ring and here you have your deep inguinal ring. So this is the superficial inguinal ring, this is the deep inguinal ring, and I'm asking the patient to cough. Now, when the patient coughs, you have to find where the impulse is felt. If the impulse is felt at the tip of the finger, because the tip is going, your finger which you're going to put, the tip of the finger. So this is how the finger is going to go. The tip of the finger will be at the deep inguinal ring. Now, if you feel the impulse at the tip of the finger, it is your indirect inguinal hernia because the entry point of indirect inguinal hernia is through the deep ring. But if you feel the impulse at the base or the pulp of your finger, it is your direct inguinal hernia. In this patient, when we asked the patient to cough, I felt the impulse at the pulp of the finger. This is a direct inguinal hernia. I want you to observe it again, right? See, superficial inguinal ring, deep inguinal ring, I'm asking the patient to cough. Now you see the finger is moving. If the impulse is felt at the tip, it is your indirect. If it is felt at the pulp, it is your direct inguinal hernia. So answer to this question is going to be your finger invagination test. For ring occlusion test, in the ring occlusion test, what are you going to do? I am going to use the thumb. We will use the thumb to occlude deep inguinal ring and ask the patient to cough. And ask the patient to cough. Ask the patient to cough. And if I find the impulse to be positive, even after occluding the deep ring, then the answer is direct inguinal hernia. If the cough impulse becomes negative after occluding the deep ring, it is an indirect inguinal hernia. The exception is pantaloons hernia because it's a fallacy. In a pantaloons hernia, because you have direct and indirect, either you occlude or do not occlude, you're not able to differentiate. Another fallacy is if there's a lax deep inguinal ring, you try to compress it, your thumb will not be able to compress the entire deep ring, you'll still get it positive. Those are the fallacies of your ring occlusion test. None of the above cannot be the answer. So answer to this question is B for Bombay. That is your finger invagination test. Everybody clear with that? Okay, sorted hai? Okay, chalo, great. Now, moving to the second question. So the question number 2 is this. I have a 30-year-old male presented to us with a discomfort in the periumbilical region. Great. The patient was examined. The examination video is attached to identify the sign demonstrated, right? And I'm going to show you a video. Now, this is a 30-year-old male with an incidentally found swelling in the periumbilical region. There is no other medical history. I'm going to show you the clinical sign and I want you to identify. I want you to identify what is happening, right? Now, this is the patient and this is the clinical video. Now I am seeing the swelling is present in this axis. That is what I'm trying to tell you. Now if I press here, the swelling becomes more prominent on the other side, right? You can see here, you can see that's getting more prominent. And then when I press from this side, when I press it from this side, the swelling becomes more prominent on the opposite side. So if I'm pressing here, the swelling is becoming prominent. Now I press here, look at here. The swelling will become more prominent here. The swelling is becoming more prominent, right? Now, as I press, the swelling becomes more prominent on the other side. So the swelling is orientation in this manner and it is only mobile in this particular manner. And when I perform a percussion, see, I'll also do percussion on the swelling. Very good, Anuj, very good. So what is this sign? क्या है ये sign? What is this sign? I'm also doing percussion. I'll find the dull node and there'll be band of resonance around it, right? So I have a patient, 30-year-old, periumbilical swelling is present. Now it is only mobile in this particular direction. It is not mobile along its direction, and I'm also doing percussion. If you find a video like this, what is the possibility? What is the possibility? Last time also it happened this way, no? Wait. One second, guys. Just hold on for a second. Fortunately, this time nothing happened. So we are good. Now, what is this sign? Now, what is this sign that you're seeing across here? Now, is it a Murphy sign? See, Murphy sign is... No, don't worry. We got this time back. Now, what is Murphy sign? Murphy sign you will find where? Where would you actually find the Murphy sign? Murphy sign would be found. कहाँ मिलेगा Murphy sign? Where would you find Murphy sign? So Murphy sign positive basically indicates that there is whenever mid-inspiratory arrest or deep palpation in the right hypochondriac region. So presence of mid-inspiratory, there's a mid-inspiratory arrest on deep palpation, on the deep palpation in right hypochondriac region. Now this usually we see in cholecystitis, right? This is not here. McBurney sign is in the appendicitis. This is what we call it as the Tilloch sign. So what is Tilloch sign? The Tilloch sign is the swelling that you're going to palpate. The Tilloch sign, when you look at the Tilloch sign, so Tilloch sign you'll usually find it is in mesenteric cyst. The mesenteric cyst usually arises from the mesentery. So you have two types, chylolymphatic and enterogenous, which is more common. Obviously, the chylolymphatic is more common when compared to enterogenous cyst. Now, in the Tilloch sign, you will see that the swelling is mobile. It is mobile perpendicular to mesenteric attachment. Perpendicular to the mesenteric attachment and immobile, and it is immobile along the mesentery. And also there is a band of resonance. There's band of resonance. There's band of resonance around the swelling. There is band of resonance around the swelling. This is what we call it as Tilloch sign positive. right? Cullen sign, as you see, it is, okay, somebody saying it is pancreatitis, but it is hemorrhagic pancreatitis. Cullen sign positive will be seen in retroperitoneal hemorrhage. It's a periumbilical ecchymosis. This is periumbilical. This is a periumbilical ecchymosis. And this periumbilical ecchymosis is seen in retroperitoneal hemorrhage. It is the retroperitoneal hemorrhage. It is seen in the retroperitoneal hemorrhage. What are the other signs? You can also see the Fox sign. You can also see the, you have the Cullen sign, Gray Turner sign, and the Fox sign. Okay? Fox is along the inguinal region. Cullen's is periumbilical, and Gray Turner is a flank ecchymosis. There are three signs that you're going to watch it. Okay? Great. So we have finished the two questions. Let's go to the question number 3. Something is happening. Okay. So going on to question number 3. Now, in the question number 3, what do you have? In the question number 3, now this is a very interesting question. Okay. Now, in question number 3, I have a 55-year-old female, short statured, presented to us with pain in the groin region. Okay. Which was intermittent in nature. Great. The patient is examined. There was no swelling identified in the groin region. The following clinical test was performed and the sign was found to be positive. Identify the test and the diagnosis, right? Now, I'm going to show you the video. You have to find me what test it is. And your 4 options: Hannington-Kiff sign, Hausche-Bromberg sign, Fox sign, Gray Turner sign, right? Now, even before we start with the discussion, the basic consensus is clear already, right? What is the basic consensus that we have? The basic consensus is that Hannington-Kiff sign and Hausche-Bromberg sign are the 2 signs that you see in obturator hernia. These are the 2 signs we see in obturator hernia. Fox sign and Gray Turner sign is seen in retroperitoneal hemorrhage. It is a retroperitoneal hemorrhage. This is your retroperitoneal hemorrhage, right? Now we have an absolute clarity of thought that if you have Fox sign, which is going to be ecchymosis around the inguinal region, Gray Turner is going to be ecchymosis in the flank region, I have to differentiate between Hannington-Kiff sign and the Hausche-Bromberg sign. As simple as that. ठीक है, चलो देख लेते हैं. Now this is the question, right? I'm going to show you a clinical video. You have to identify. But diagnosis is obturator hernia even before starting the video. But I want you to identify what clinical test is being performed here, right? Now, I have a hammer in my hand. Patient is sitting. This is the knee. This is the medial aspect, right? Now, watch it. I have palpated the medial epicondyle of the femur and I have tapped it, right? On tapping the medial epicondyle of the femur, there is sudden jerk at the hip. What is the sign called as? बेटा Hausche-Bromberg sign नहीं है, वही तो हम बता रहे हैं. क्या sign है ये? I'll play it again. I'm tapping on the medial epicondyle and you see there is jerk at the hip. क्या sign है ये? This is your Hannington-Kiff sign. This is your Hannington-Kiff sign. ठीक है? Hausche-Bromberg sign क्या था? Hausche-Bromberg sign, there will be shooting pain along the obturator nerve on medial rotation of the semi-flexed thigh. वो आपका Hausche-Bromberg sign है. ये Hausche-Bromberg नहीं है. ये क्या sign है? This is your Hannington-Kiff sign. This is your Hannington-Kiff sign. When you tap on the medial epicondyle or the medial condyle of the tibia or the medial epicondyle of the femur, there will be abduction of the limb because of jerky movement at the level of hip. And this is what we call it as the Hannington-Kiff sign positive. ठीक है? चलो. Going on to the next question. Now this is also a very interesting question. I want you to pay a little bit of attention. देखो video based questions ना थोड़े tricky हो सकते हैं अगर आपका concept clear नहीं है. ठीक है? तो my job is to make sure your concept is sound and good here. Now I have a 14-year-old boy presented to us with a swelling in the left side of the chest. Started 5 days ago. Started 5 days ago. Right? And present status of the swelling is given in the video. The patient is a known case of pulmonary tuberculosis. On chest X-ray, it was suggestive of left-sided empyema. Identify the diagnosis. I have 4 options that I have. What are the 4 options that I have? Option number 1, is it a cold abscess? Is it an empyema necessitans? Is it a chest wall abscess? Or all of the above? Clear? Okay, let's look at the video. Now, this is 2-part video that you have. I'll show you both the parts of the video and you have to identify the diagnosis. Now, let's look at the first part of the video. Look at the swelling. I hope you're able to see. The swelling is in the anterior chest wall that you can see here. I'm asking the patient to cough to see whether it expands or not. And it is basically a fluctuant swelling. You can see here, the swelling is quite evident, right? This is the first part of the video. Now, in the second part of the video, what we did, because on the chest X-ray, it was suggestive of empyema, I'm going to put this tube. What is this tube? It is an intercostal drain. Now, after putting an intercostal drain, the swelling disappeared. The swelling disappeared and the bag is now filled up with purulent material. The bag is now filled up with the purulent material. Now, my question to you is, what is the diagnosis? You had the swelling before putting the ICD and swelling disappeared after putting the ICD. Before there was a swelling, there was nice swelling, there's some sinuses also there, but after putting the ICD, the swelling disappeared. That means it is communicating with the thorax. Which swelling or which of the following options will have an intrathoracic communication? Quick feedback. ऐसा कौन सा swelling है जिसका intrathoracic communication होता है? Cold abscess, it is because of necrosis of the lymph nodes. So ये cold abscess तो नहीं है. Yes, the answer is correct. It is your empyema necessitans. The empyema necessitans communicate with the intrathoracic cavity. And that is why the minute I put the ICD, swelling also disappeared. That's a very, very important point. In fact, empyema necessitans में IND नहीं करना है. You have to put an ICD and you should make sure the swelling regresses and disappears. ठीक है? It is not a chest wall abscess because chest wall abscess would not change in size even after putting the ICD. All of the above तो वैसे ही नहीं है. तो answer here is B for Bombay. Everybody is clear? ठीक है? It was a good case and a good video discussion. Sorted? Chalo. Moving on to the next question. Now, let's take the next question. Okay. The next question is, identify the test performed. I'm going to show you a video. You have to find. Now, if I say slip sign, now the slip sign is seen in lipoma. Fluctuation test will be positive with any fluid-filled cavity or a fluid-filled swelling. Transillumination is going to be transparent, or you can say bright light, indicating of clear fluid. Pinch test, it is done whether the swelling is to identify the origin of the swelling. To identify the origin of the swelling. Is it originating from the skin or the underlying? If the skin is pinchable, that means it is originating from the underlying tissue or the underlying structure. If the skin is not pinchable, that means the swelling is arising from the skin itself. As simple as that. All right? Okay. Now, I'm going to show you the video and I want you to identify what is the sign or the test that we have performed. But a fluctuation test can be positive in any fluid-filled swellings, right? And transillumination is positive in the neck, it is in cystic hygroma. Hydrocele, they will have positive, right? So myelomeningeocele, they are positive, correct? Okay? So wherever you have dermoids, they don't have positive fluctuation, positive transillumination. Dermoids can have positive fluctuation test. Okay? Now, I'm going to show you the video and you are going to tell me what is the test that you are going to perform. Now, there is swelling in the calf. I fixed it with 2 fingers and I'm now going to press at the summit of the swelling. Right, now you identify what is this. I have the swelling, right? I'm pressing at the summit and you see my fingers are moving apart, right? I'm pressing in the between, the swellings, the fingers are moving apart. What is this test called as? Is it a slip test? Slip test is what? You press, the swelling moves away. Are you doing that? No. Is it a fluctuation test? If you're pressing, fluctuation test is basically if you have a larger swelling, you put 2 fingers at the end of the swelling. You press one, the swelling goes, this finger goes up, and you press from here, this finger goes up. Because this swelling is fluctuant, the fingers will also move up and down. This should be done in 2 perpendicular direction. That is what we call as fluctuation test positive. But if the swelling is too small, you can't put 2 fingers, you can do this. So this is a fluctuation test. Absolutely spot on. Okay. Transillumination, I did not put any light, so it is not a transillumination test. It is not a pinch test because I'm not holding the skin and pinching it, right? So answer here is going to be your fluctuation test. So the test that we have performed, is B for Bombay. That is your fluctuation test. Clear? Okay. So this was your next question. Okay. Okay. Going on to the next question. Now, this is also a very anticipated exam question. I'm thinking this will come. Okay. Laparotomy 10 years ago. Okay. Now, I have a 45-year-old male patient presented to us with the following condition in the video. Okay. The patient underwent laparotomy 10 years ago. So, there's a previous history of surgery 10 years ago for a hollow viscous perforation. Okay. Could be because of peptic ulcer disease. According to EHS, that is European Hernia Society classification, what hernia is this? Is it an M1 hernia? Is it an L1 hernia? Is it an F hernia or an M5 hernia? Okay. So, what was the location of swelling in the video? It was on the scalp, beta. It was on the scalp. Okay. Now, I have a 45-year-old male presented to you with the swelling in the, I'll show you the video. Okay, let's see the video and then we'll come back to this question. Okay. Now, this is the patient that we have. You can see a previous laparotomy scar is present. Now, this is the condition of the patient. This is the condition of the patient. Absolutely correct. Okay. So, it is not a rocket science to identify that it is an incisional hernia. But I've twisted the question by asking you, according to European Hernia Society classification, what category does it belong to? Now, for that, you should know the EHS classification. Now, according to EHS classification in the incisional hernia, if you take this as the representation of the abdomen, and you take this as a representation of the umbilicus, right? So, the hernia that is going to be present within 3 centimeters of the xiphoid is called as subxiphoid. This is your M1 hernia. Now, within 3 centimeters of the umbilicus, it will be called as the umbilical hernia. So, this is your M2 hernia. This is your M3 hernia. This is your M4 hernia. And if you draw the line passing through the two anterior superior iliac spine, below this is suprapubic. This is a M5 hernia, right? So, these are M1, M2, M3, M4, M5. Now, our patient is having the incision in the periumbilical region, which is here. So, it is involving M2, M3 and M4 region, right? So, because of the laparotomy that you have. So, incisional hernia is in this region, right? Now, you tell me, according to this, right? So, you have entire laparotomy scar. So, the laparotomy is going to be from the xiphoid to that of the suprapubic region because the complete laparotomy, right? Now, in the given options, the midline option is only one, that is M1. So, L1 is your lateral hernia, which is going to be subcostal, right? So, it is not L1, right? I can eliminate the L1. I can eliminate the L1. F stands for femoral hernia, that is for inguinal region. M5 is going to be suprapubic, it is pseudo, right? So, it is more likely to be in the upper part. So, it is your M1 hernia. It is your M1 hernia, right? So, see again, if you look at the video, you will have more clarity on the question. Okay? Again, look at this. So, if I just point it out, this is the xiphoid, this is the pubis. The swelling is more towards the upper side, right? I want you to identify as I play the video. See here. Look at this. Look at this, right? So, hence, it is more in favor of M1. That is why I want you to watch the video, no, beta. So, it is very unlikely to go into suprapubic because usually incision does not cross the ASIS. The level of ASIS is the lower extent of your laparotomy incision. And that is again a very, very important clinical point. Okay? So, M5 is very unlikely. So, M1 is a better answer here. Okay? Clear? Clear? Chalo. Moving into the next question. So, what do you have in the next question? Okay. The next question says that the following test was performed in the swelling found in the inguinal region. based upon the video, identify the diagnosis, right? Pretty straightforward question. I will show you a video. उसमें एक टेस्ट होगा, उस टेस्ट के बेसिस पे आपको मुझे बताना है कि कौन सा हर्निया है. Is it an indirect inguinal hernia? Is it a direct inguinal hernia? Is it a femoral hernia or is it an obturator hernia? As simple as that. ठीक है. Obturator hernia नहीं हो सकता because usually we talk about Hauscher rhomboid sign and Hannington-Kiefsen, वो हमने already discuss कर लिया. So let's go with the video and see what. So question is, I've done a test. Based upon the test, you have to tell me whether direct, indirect, or it is going to be an femoral hernia or an obturator hernia. And this is the video that we're going to play. Now, in this video, you can see I've used 3 fingers that is there. The first finger is your index finger. Okay. So this is your index finger, this is your middle finger, this is your ring finger, and now I am asking the patient to cough. Now, when the patient coughs, you can see the impulse is present on the lower finger, right? It is at the level of the lower finger. So what is the absolutely correct? This is a Siemens test. Okay. So where did you find the impulse? Where did you find the impulse? So 3 fingers are there. You have put the fingers like this. Okay. And you felt the finger impulse on your index. Yes, the answer is femoral hernia. This is your femoral hernia. This is a Siemens test. This is your Siemens test, or also called as the 3-finger test. Also called as the 3-finger test. Last time also we have discussed the same question. Okay? Chalo. Okay. Okay, moving on to the next question. Okay. So again, an interesting case. Let's see this also. Now, I have a 4-week-old male child presented to us with the repeated episodes of vomiting, and the clinical presentation of the baby is given in the video. Identify the diagnosis. Let's look at the clinical video. 4 weeks old male child, repeated episodes of vomiting. I know where it is going. You have options like CHPS, duodenal atresia, interception, and esophageal atresia. See, duodenal atresia will present to you on day 0 or day 1. So I already rule out this. Esophageal atresia will also present to me on day 0, day 1. So again, I can rule out this. So I'm left out with CHPS and interception because that can occur at any age group. But interception usually occurs between 6 to 10 months of babies. So by the virtue of the question, I already know the answer is CHPS. But I want you to look at the clinical video and give me the objective. Now, this is the baby with repeated episodes of vomiting and something. This is what you're going to see. Tell me, what do you see in the video? That is more important. What do you see in the video? A very classical sign that you're going to see. I'm just going to move away from here. What do you see in the video? But it's not a rocket science. You can already know it's a CHPS. What do you see? There is some lump or a swelling, and that swelling is not at one place. It is moving. Where is it moving? It is moving from the left subcostal region towards the umbilicus. So there is a moving swelling from left to right. What is this? Yes. Yes, it is an olive lump and that is moving from left to right. It is a visible gastric peristalsis. How am I able to tell you it's a gastric peristalsis? You see the peristalsis, you see the swelling moving from the left to right. If it is moving from right to left, it is colonic. If it is moving from left to right, it is gastric peristalsis. 4 weeks old baby, repeated episodes of vomiting, olive-shaped lump and a visible peristalsis, and that to gastric peristalsis goes in favor of congenital hypertrophic pyloric stenosis. Yes, even before we started the video, you already knew the diagnosis. No rocket science in this. Clear? Okay? Right. Absolutely spot on. Chalo. Moving on to the next question. Now, this is also very, I would say, possible exam question because they have already asked you this question in a image-based format, right? So now we are asking you in a video-based format. So identify the method of the thyroid examination done in the video, right? Now, I've given you optional Lahey, Skriles, Pizzilo's and Rose method. Rose is not a position in which you examine the thyroid. It is the position for thyroid surgery. It is a position for thyroid surgery. So I can ready-made rule out the rose position. Okay, it's an hyperextension of the neck, as simple as that. Now I have Lahey's method, Kryle's and Pizzilo's method. Okay, acha. Now Pizzilo's method is done for short statured female, for short and obese neck. Now how do you identify Pizzilo's? The patient hand is behind the head. जो पेशेंट के जो हाथ होंगे ना, पिजिलोस मेथड में आपके पेशेंट के दोनों हाथ ऐसे क्लास्प होंगे और पीछे होंगे. अगर इस पोजीशन में आप पेशेंट का थायराइड एग्जामिन कर रहे हो, देन इट इज गोइंग टू बी योर पिजिलोस मेथड. क्राइल्स में आई विल बी यूजिंग थंब, एग्जामिनर का थंब होगा. सो एग्जामिनर is going to use the thumb and I'll ask the patient to swallow. I'll put the thumb, I'll ask the patient to swallow and the swelling is going to move against my thumb. That is your Kryle's method. Lahey's method जो होगा, examiner is going to stand behind the patient. Examiner stands behind the patient. Rest the thumb on occiput. Rest the thumb on occiput and use fingers to palpate the thyroid gland. To palpate the thyroid gland. This is what you call as Lahey's method. In the Lahey's method, the thumb is going to be on the occiput, the fingers will come forward. From one side, I'll press this swelling, it will become more prominent. I'll feel from this side, and then I will press from this side, and then I'll feel from this side, right? So this method is what we call as Lahey's method. Now I have oriented you pretty well. I'm going to show you the clinical video. See, at the end of the clinical video, I just want you to tell me what is the diagnosis. ठीक है? अच्छा, देखो. Now this is the patient that you have, right? And this is the method by which you are examining. So I'm using my fingers to palpate and my thumb is resting on the occiput. Thumb occiput mein I'm using the fingers to palpate. What do you think the diagnosis is? The answer is pretty straightforward. This is your Lahey's method. Kryle's में तो thumb है, हमने thumb तो use किया नहीं, ठीक है. Pizzilo's में patient का हाथ पीछे होना चाहिए, patient का हाथ तो दोनों साइड में. तो answer here is going to be Lahey's method. Sorted? Clear है? ठीक है, चलो, great. Now, going on to another question. ये थोड़ा difficult हो सकता है, but then I hope because you all are very intelligent, so I'm assuming that even before I start the question, you'll know the answer. ठीक है, चलो. What is the question? I have a 62-year-old male presented to us with the features of dynamic bowel obstruction with the history of laparotomy. It is laparotomy. History of laparotomy 25 years ago. Now, I've given you the video provided to you. It is not interrogative image. It's a video provided to identify the cause. Identify the cause for obstruction. Identify the cause for the obstruction. Okay? So I have a 62-year-old male who has underwent laparotomy 25 years ago for some XYZ reason. Now the patient has now presented to you with dynamic bowel obstruction. I'm going to show you the intraoperative video and you have to tell me what is the reason for obstruction. Is it because of bands, stricture, volvulus or internal hernia? Based upon the video, you have to identify what you see inside the video. Are you ready? Okay, chalo. So this is the laparoscopic video that we are going to play. It's a 13-second video. Identify what is going to happen. Reason for bowel obstruction, right? Now you go inside. As you're going inside, now you see something is there. I want you to identify what are these, right? Now the obstruction is because of these structures. So what are these? And these are the causes for obstruction. There are multiple of them, not one. There are 2, 3 of them. And because of that, the bowel can twist around that and cause obstruction. Cause for obstruction, beta. Cause for obstruction. Cause for obstruction. Yeah. Very good. This is your adhesions or bands. So this is your post-operative adhesions. This is your post-operative adhesions. This is your post-operative adhesions, which has caused the dynamic bowel obstruction. In fact, the most common cause for dynamic bowel obstruction is post-operative adhesions or bands. There are no strictures here. Volvulus, it should have rotated around its own axis, and it is usually in sigmoid colon. There's not there. For an internal hernia, the patient should either have a history of surgery where you have mobilized a bowel loop, example like Roux-en-Y surgery, very, very important. Or there should be a potential defect through which it is going to herniate. Either it has to be from the foramen of Winslow on top, or either side you have on the superior mesenteric artery and the inferior mesenteric artery, potential defects are there. Either has to herniate from there. In a Roux-en-Y limb, if it herniates through the transverse mesocolon, it is called as the Stammer's hernia. If it goes behind the Roux limb, it is called as Peterson's hernia. But those are not the case here. So answer here is going to be Banks. ठीक है बेटा स्ट्रक्चर में ना बावल लूप कंडेंस होता हुआ दिखेगा यहां पे बैंड्स क्लियरली नजर आ रहे हैं ना तो आंसर हियर इज गोइंग टू बी पोस्ट ऑपरेटिव बैंड्स ठीक है सो आंसर इज पोस्ट ऑपरेटिव बैंड्स ठीक है नाउ लेट्स डू अ क्विक रिव्यू Question number 1 क्या था? I have a 46 years old male presented to us with a swelling in the inguinal region. The following test was performed. Identify the test performed. Was it a 3-finger test? Was it a finger invagination, ring occlusion, or none of the above? उसके लिए हमने वीडियो आपको क्या दिखाया था? ये वीडियो था in which I have shown you this, right? So I have an index finger from the superficial inguinal ring going into deep inguinal ring, and the positive cough impulse or the impulse is found to be positive. Now, what is the interpretation? When you put the finger from the superficial inguinal ring going into deep inguinal ring, when the cough impulse is felt, if it is felt on the tip of the finger, it is indirect inguinal hernia. If it is felt on the pulp of the finger, it is a direct inguinal hernia. So question number 1 का answer था finger invagination test. The question number 2 was this. A 30-year-old male presented to us with the discomfort in the periumbilical region. Patient was examined. The examination video was given. Identify the sign demonstrated. And the video that we showed was this. In this video, we were trying to tell you that the swelling is very well defined in the periumbilical region, and the orientation of the swelling is in this direction, that is along the line of the mesentery. When you start palpating it, you will notice when you press the swelling, in whichever direction, the opposite direction becomes more prominent. You've pressed from the right iliac fossa, it becomes on the left lumbar. Again, left lumbar, it becomes right iliac fossa. So basically, the swelling is moving perpendicular to the line of attachment of your mesentery. Now, when you do the percussion also, on percussion, I will find the band of resonance along the dull node. And this sign is what we call it as the Tilloch sign positive. You can see as I'm pressing, it is becoming more prominent on the other side. The movement is only along the perpendicular to the direction of the mesentery, not along, right? So the swelling is moving perpendicular to the mesenteric attachment. Okay, from the DJ flexure, all the sacroiliac joint, from DJ to sacroiliac, this is the line of the mesenteric attachment. Do not forget that. So answer here is going to be Tilloch sign positive. We have discussed the other components also. The next question was, I have a 55-year-old female, short-statured, pain in the groin region, intermittent in nature, no swelling identified, and this is the video that we said, and we asked you to identify the sign. Here I am taking a hammer and tapping at the medial epicondyle of the femur, and I'll see a jerky movement at the hip, and this is what we call it as positive Huntington-Kiff sign. You can see I've tapped it and there is a sudden jerk at the hip, and this is called as Huntington-Kiff sign positive, seen in obturator hernia. Next question, I have a 14-year-old boy with swelling in the left side of the chest, which started 5 days ago, and then the patient's swelling was given in the video. History of pulmonary tuberculosis, X-ray was suggestive of empyema, and we have the option, what is this, cold abscess, empyema, nesta, and cestual abscess, all of the above. The video that I showed was this. There's a swelling that is present initially, but after putting the ICD, swelling disappeared, right? So you can see very clearly the swelling before putting the ICD, it was quite evident. The swelling was well visualized. It is present on the anterior chest wall. And once you have done this, right, because the X-ray was suggestive of empyema, what we did next was to put a ICD. Now, once we put the ICD, you can see both the videos are playing simultaneously. Swelling is there. After putting the ICD, swelling disappeared. Now, once the swelling disappeared, it is a classical case of empyema necessitans. Okay. Next, we said identify the sign shown in the image. This is, or the video. This is what we call it as the fluctuation test positive. Your press for smaller swellings, you fix it to fingers, press on top, your fingers are going to move away. I want to see your fingers are moving apart. As the test has been demonstrated, you see your fingers are moving apart, and that's a positive fluctuation sign positive. So it's a positive fluctuation test. Now, we have a patient previous surgery of laparotomy now presented to you with this presentation. Obviously, no pointers, easy to diagnose. This is an incisional hernia, but according to EHS classification, what incisional hernia is this? And we have given the EHS classification from midline. Subxiphoid is M1, then epigastric is M2, periumbilical is M3, hypogastric is going to be M5, suprapubic is hypogastric is M4, suprapubic is M5. Now here the swelling is more towards the M1, M2 area, so it is according to the options, M1 is a better answer, right? Now, this I think we have done last time also, Siemens test, that is your 3-finger test. And in the 3-fingers test, you can see the impulse present on the lower finger. This is going to be a femoral hernia positive, right? Siemens is positive, done. This was also a very good case. 4 weeks old baby, repeated episodes of vomiting, and we showed you this video. In this video, it is quite evident there's an olive-shaped lump which is present initially arising on the left side or the left upper abdomen and slowly drifts towards the right side. Olive lump, visible peristalsis moving from left to right. It is gastric peristalsis, and the answer is going to be congenital hypertrophic pyloric stenosis. Then we asked you identify the method of thyroid examination, and this is the video that we showed you. Examiner is standing behind the patient, the thumb is fixed and the fingers are moving. Now you can see this is what we call as Lahey's method. Cryles, we use thumb. Pizzilos, the patient's hands are going to be clasped behind the head. Rose is a position in which you operate. The last one is patient underwent laparotomy 25 years ago, now presents with dynamic bowel obstruction. I've given you intraoperative video and I've asked you to identify the diagnosis. You can clearly see post-operative bands and adhesions are clearly visualized, and this is the reason for intestinal obstruction. So answer to this question is post-operative bands, right? So this is all in all that we had for today's discussion. Now, one more very important announcement that I have for all of us, quite important. We are starting the video-based Gland test. It is now live on the app. You can just go down to our app and then you just need to choose test series and GT is live there, right? You go there and you can access it. All that you have to do is to download the app, register it, and attempt a live exam and then analyze the exam. Now, this is available on the app. It is live from yesterday itself. And these are the dates that we're going to put the GTs for. The first GT is on 25th July, second is on 28th July, third is on 1st July, 1st August, and last is on 5th August, right? So give these GTs. These are the GTs which also have video-based questions also. So it is going to help you a lot, all right? So if you have any questions, any queries, do reach us out. I'm going to upload the same videos and the same questions and same explanation on the app also. You can go check it down and you can revisit them. If you have any questions, you can reach out to me personally also. I hope everybody knows where to reach me out. If you have any questions, any queries, it is available. I'm available on the Instagram. It is by the name The Surgery Guy. Those who don't know me, I am Dr. Sandeep. Right? Any questions, any queries, just reach out. I'll be there to help. We also have a support group on WhatsApp and Telegram. And if you have any questions, reach us out there on the Meded app as well. Thank you so much for joining. Take care.